Yep.
Welcome everyone to our February CPD webinar. It's my great pleasure to introduce our two speakers this afternoon. We have Suzanne Henry and Sany Dangol, and their presentation is going to discuss supporting radiation therapists in practice-based learning, practical strategies and innovations for the clinical setting. And by way of introduction, I might start with Susan first. So Susan is a clinical specialist radiation therapist with over 26 years experience and is currently working in the west of Ireland in Galway University Hospital. For the past 3 years, she has worked as the practice clinical tutor, focusing on clinical education, assessment processes and supporting staff and students in the learning and practice. She is nearing completion of her Masters in Clinical Education and has a strong interest in promoting the profession, organising student outreach initiatives and contributing to health and social care professionals working group aimed at attracting future healthcare professionals. Sany is also an experienced clinical specialist radiation therapist working in the St. Luke's Radiation Oncology Network here in Dublin, Ireland. And he has more than 10 years experience. And for the past 4 years, Sany has been working as the practice tutor across the St. Luke's Radiation Oncology Network, which includes St. James's Hospital, Beaumont Hospital and St. Luke's Hospital here in Dublin. His role involves supporting clinical education and assessment for both staff and students, and Sany holds a postgraduate certificate in health professional education. Before we kick off, just a reminder that your mics are muted and will remain muted for the duration of the webinar. But if you do have any questions or comments, if you post them in the Q&A chat function, I'll be able to put them to Sany and Susan at the end of the call. Okay, Susan and Sany, the floor is yours. Looking forward to hearing what you have to say.
Okay, thanks, Laura, and welcome everyone, and thank you for joining us today. As Laura said, my name is Susan Henry, and I work here in Galway as the practical clinical tutor. So today we're going to focus on practical, evidence-informed ways that clinical education can support both learners and colleagues in busy radiotherapy departments. Don't think the session is going to be about adding more work. It's really about recognising and supporting what we're already doing with students and sharing some practical approaches that hopefully can make clinical teaching feel more manageable within everyday practice. We'll be drawn on clinical experience, educator practice, and what we know from the research. So before we go any further, I just want to briefly step back and talk through what the role of the practice clinical tutor actually involves. So firstly, our role is not about teaching everything or having all the answers for everybody. Excuse me. It's really about supportive learning across the whole clinical environment. First and foremost, it's about supporting student learning. So we help students make sense of what they're seeing and doing on placement and guiding their learning as it happens in practice. A big part of the role is also supporting radiation therapists who are supervising and mentoring students every day. We like to see ourselves as someone you can check in with, problem solve with, or get advice from when challenges come up. The third part of our role is really about the support we offer to staff around coaching, feedback and assessment. This could include things like talking through tricky assessment decisions, helping phrase feedback, running training on completing assessment forms, and keeping everyone up to date with any changes or expectations. Alongside that, we focus on helping students develop as reflective practitioners, encouraging them to learn from feedback, build confidence, and grow into independent and professionals. Finally, we act as a link between the university and clinical practice. We help to bridge that gap between academic expectations and the realities of the clinical environment, supporting progression and helping students feel prepared for practice. So just to give you an overview of today's session. So we're going to start by looking at why clinical education really matters right now, and not just from a student point of view. It also matters for departments, services, and the profession more broadly. Then we'll spend a bit of time acknowledging some of the challenges that come up with practice-based learning. These are things most of us will recognise from our own departments. We'll then look at what helps in real clinical settings. This is where we'll spend most of our time today. We'll focus on practical things that actually help learning in real busy clinical environments, not ideal world solutions. We'll also share a few examples of different or more innovative approaches that people are using to support learning and practice, especially when time or capacity is tight. We'll finish by pulling out a few key takeaways and opening things up for any questions you might have. This session isn't about identifying problems, it's about acknowledging the reality we're all working in and thinking about how we can support learning within those constraints. So what is clinical education? Why does clinical education matter, and why are we discussing it today? So clinical education is where theory actually gets translated into day-to-day practice. Students might learn concepts in university, but placement is where they apply that knowledge with real patients and real decisions. And that's what prepares them to function safely and effectively once they qualify. But it's not just about applying knowledge. Placement doesn't just build competence, it builds confidence too. Giving students small but real responsibilities really help them feel capable rather than just observing. And confident graduates are much better able to step into independent practice from day one. And that confidence links directly to patient care. Placement is where clinical judgment develops. Learning what to prioritise, what to double check, and knowing when something just doesn't look right. That judgment is what keeps our patients safe. So strong clinical education directly supports safe, high quality care. It's also where professional identity develops. This is where students stop feeling like just students and start seeing themselves as radiation therapists, thinking, talking, and feeling part of the team. And when people feel they belong, they perform better and feel more confident in their role. And that sense of belonging doesn't just affect learning, it affects workplace decisions too. Research consistently shows students often take jobs in departments where they had positive placements. So clinical education isn't an added extra. It influences confidence, patient care, professional identity, and ultimately who stays in our workforce. The question then becomes, how does that learning actually happen in practice? One helpful way to understand how students actually learn and practice is through the idea of communities of practice. It's simply the idea that learning happens by being part of a clinical team, not just through formal teaching. So students learn by observing how work is done, how decisions are made, and how people interact day to day. Over time, they move from observing to contributing to participating more actively. It's that participation that really drives the learning. Students learn best when they actually feel part of the team, when they start to think, talk, and act like radiation therapists. That sense of belonging builds both confidence and professional identity. In practice, that might be small things, involving them in handovers, safety pauses, maybe representing the team at weekly MDMs, just giving them real responsibilities rather than just watching and observing. Near-peer learning is really important too. New graduates often bridge that gap between student and professionals. They're often more relatable and approachable, so students feel comfortable asking questions and speaking up with them. Research has shown this works really well. And this is where we come in as clinical educators. Our role is about nurturing this culture, supporting, mentoring, encouraging reflection, and creating that inclusive environment. And importantly, this doesn't usually mean extra teaching. It's mostly about being intentional in everyday work. Of course, we also know this isn't straightforward in reality. There are real pressures that make this difficult. So let's just look at some of those challenges next. These are challenges that are not unique to Ireland. They're being experienced internationally. The World Health Organization has highlighted that service pressures and insufficient protected time as global issues. So we're not here to pretend the system pressures don't exist. They're really the reality of a modern radiotherapy department. And it's not just time pressures. Clinical work itself has become more complex over the years. We're now dealing with advanced technology, detailed protocols, higher cognitive demands. All these things combine to make teaching feel much harder in the moment. The challenge isn't a lack of commitment to education. It's how we teach effectively within the busy clinical environment. Students don't need long teaching sessions. What they really need is access to our thinking. While university teaching supports the clinical environment, students come on placement to see how that knowledge is applied in practice and develop their practical skills. Talking through decisions, even briefly, turns into learning. And most importantly, consistency matters more than perfection, especially when multiple educators are involved. Clinical education doesn't have to compete with service delivery. It's embedded within it, in the small teaching moments that happen during normal working clinical work. We'll now move on to some practical tips and strategies that you can incorporate in how you already support students in the clinical environment. These are small, realistic approaches that can enhance placement experiences for both staff and students without hopefully adding any extra pressure to your already busy day. So what actually makes a placement experience positive? One of the biggest things is simply culture. When students feel welcome, included, they're much more likely to feel that they belong. Often that comes down to really small things, introducing them properly to the team, involving them in conversations, or simply treating them as part of the group rather than the student. And that sense of belonging has a big impact on confidence, engagement, and learning. Structured feedback and mentoring help students understand how they're progressing and what's expected of them. It's not about constant supervision. It's about knowing someone is invested in their development and supporting them to grow. Sany is going to share some really practical ways we can do this in a few minutes. In practice, we often see that students apply for jobs in departments where they feel supported during placement. Placements aren't just about learning skills. They're also where students start deciding where they want to work. So this isn't just a nice extra. Research consistently shows that positive placement experiences influence future employment choices. That means student education isn't only a teaching responsibility, it's actually a workforce strategy. Investing in student experience is investing in future recruitment and retention. One simple but really powerful way we can support students in practice is by making our expert thinking visible. Making expert thinking visible simply means saying out loud things that usually stay in our heads when we're working clinically. Students are very good at watching what we do, how we set up patients, how we match images, how we move through the day. What they can't see is thinking behind those actions unless we say it out loud. As experienced therapists, a lot of our decision making becomes routine and automatic. We know what to check first, we know what matters most, and when something doesn't feel quite right, we know it, but we don't always articulate that to the students. When we talk through our thinking, we're helping students move from simply observing actions to developing clinical judgment and reasoning. This is particularly important for things like cone-beam matching, prioritizing checks, or adapting when a patient doesn't quite fit the textbook. It doesn't have to be a long explanation, even just a short sentence like, I'm checking this first because, or I'm being more cautious here because, just helps students understand what expert practice actually looks like. Over time, this supports confidence, clinical judgment, and readiness for independent practice. And importantly, this doesn't require extra teaching time. It's often just narrating decisions as we go. This idea underpins many of the practical strategies we use in practice. So these ideas sound simple, but we know putting them into practice in busy clinical settings can be challenging. I'm going to hand over to Sany now, who's going to share some really practical day-to-day strategies that make this achievable in real clinical environments.
Great. Thanks, Susan. And as we hand over to Sany, just a reminder, if you have any questions or comments that you'd like to put to Susan and Sany or the rest of the audience, feel free to drop them into the Q&A box and we can have a look at them after the presentation.
Thanks very much, Susan. Thanks, Laura. Hello to everyone. So the next tip is micro-teaching moments. As Susan's mentioned, a busy clinical environment, and in a clinical, we often assume that might mean giving extra time or stopping the workflow just to deliver the teaching. But in reality, that doesn't really work. That's where micro-teaching moments come in. So what is it? It's teaching that's delivered in bite-sized information at that moment. How do we deliver it? Well, it's very short comments, usually around 10 to 20 seconds. It focuses usually on one point, one skill, or one decision. You just need to be very intentional about what direction you're giving. It's embedded into the routine care or the procedures that you conduct on your clinical treatments. And most importantly, it doesn't interrupt the patient workflow. So you're not trying to deliver some kind of lecture or presentation. What you're trying to do is give that bite-sized bit of information. So there's no explanation, no discussion, and no pause in treatment. And while that might feel like, did you actually deliver any teaching? Well, the aim is to give what is actually fitting into the day-to-day practice. Later on, you can absolutely layer that clinical reasoning and expert thinking when you have the actual time for it. What does the research say behind this? Well, de Gagne et al. Did a scoping review of the literature, and he found that microlearning strategies have been used to improve knowledge and confidence for students. It also finds that delivering these smaller moments reduces the cognitive overload, which makes the teaching a lot more feasible for the educator in clinical environments. Let's have a look at that on the next slide. In this example, we can see that a setup is being performed, a breast setup, and the student is in the background learning the steps. They have been involved in some aspects, but not all, and you've noticed that. For that moment, in this scenario, you can deliver micro-teaching moments. So in this case, we can say, we are now at ISO, I'm checking these 3 things, the border, the coverage, the SSD. Remember those 3 things for the next breast setup. That's it. That's the entire teaching moment. There's no explanation, there's no discussion, there's no pause in treatment. And just like Susan's point previously, I'm simply voicing what I'm already doing, voicing the steps in the procedure, and then drawing the students to focus in on this. And again, we can deliver the layering of the clinical reasoning at a different stage of the day when there's a better opportunity. Another example where micro-teaching can also be utilized is where we build upon knowledge, especially where cognition and understanding can often be overwhelming for a student. And for an educator, it might take a considerable amount of time to deliver. Here's a breakdown of the procedure combating the issue of that cognitive overload for example, a first-year student using the micro-teaching moments. So for our first case, our moment might be to focus on patient alignment. I'm straightening the patient using the sagittal lasers and the bony anatomy. That is the focus for the student. On our second case, we focus on tattoo alignment. So we could say something like, this is the bed control for raising up the bed. I'm unlocking the bed to move into the long and lat position. Once I'm at tat, I lock the bed. If I'm off on the tattoo, I put myself back on. The third case could be a moment getting onto the target. So now I'm moving to the ISO, using the moves like this. Soup is taking away in this direction, and so on. So we cover all the steps of the treatment to a point where the student has pieced the setup together and is able to carry out that task on their own. These small pieces of knowledge embed the knowledge together to create a bigger picture for the student. And that's the power of the micro-teaching moments. It's delivering those bite-sized information that is easy to deliver by you, but has a large learning potential for the student. An RT doesn't have to spend an excessive time explaining or slowing down the clinical. Students can avoid the overload, the anxiety that's related to it, and the research supports this. And there's improved progression for the students' learning, reduction for staff frustration, and a more time-efficient learning environment. Another tip that really helps is integrating the feedback into the workflow. When we think about feedback, we often picture formal sit-down conversations, but in a busy clinical setting, we have these kind of circumstances where we might have an emergency patient. We might be 2 hours behind in our queue. We might have an MDT waiting to have a chat with us, and away we go. Now, that's not us running away from the clinical. That's us addressing our needs for a clinical setting. But often what happens is when these priorities happen, feedback isn't at the top of our list. And unfortunately, in reality, and I'm guilty of this as well, is that we have to compromise on the student education on placement. But feedback itself doesn't have to take this long amount of time or be very formal to be very effective. In fact, research shows that feedback works best when it happens as part of the normal working day. You can imagine when it's delayed at the end of the day, or if you're delivering it very late, it's often very rushed or forgotten, and the value of that feedback gets lost or diminished. So sometimes the most effective and appropriate feedback is the kind that fits into real practice, feedback that's integrated. So when we give this feedback, we deliver the feedback in the moment during the tasks. We keep it very short, we keep it very focused, and it doesn't have to follow a full model like Pendleton's model of feedback. That's just very time consuming in that clinical scenario. And usually it's a case where that conversation might even make a bladder patient empty on the bed. So what are the benefits of it? So research shows that it can be more timely and effective. So when you give the feedback at that moment, it's given immediately, it's linked to the real tasks, and it can be applied straight away. It supports continuous improvement. So you're giving it more frequently in a low stakes format, which creates an ongoing learning loop rather than this once-off high stakes review. So often like when you give it at a structured feedback session. It fits the busy clinical environment, so it can be very brief. It's in the moment feedback. It's much more feasible and sustainable to deliver. It reduces the anxiety and defensiveness around feedback. So it's normalizing the feedback that you give and makes RTs turn into coaches essentially on the unit. It reinforces the safeties. So if errors in performance are identified earlier, it promotes kind of a safety behavior and it reinforces that. And also it causes learning to happen before any harm can take place. Let's have a look at this example for integrated feedback. A student sets up a patient and you observe a gap around their mask. You could say, that was a really good check of alignment. Have a look at the gap in the neck. Next time, just make sure you confirm the chin to SS end for the chin position for a better mask fit. Verbalize that for the next 3 patients. That feedback is very immediate, it's very specific, and it doesn't interrupt the workflow. This kind of feedback feels supportive rather than stressful, and it reassures the student that they're on the right track, and it normalizes the learning as part of the everyday practice. Let's have a look at another one. So this example looks at behavioral change and a correction for students. So the student consistently nods their head in confirmation of the moves. You could say, I need you to verbally confirm the moves are correct, quantify the direction, and that I need to, and confirm that I have taken the moves correctly. The student immediately completes the task. So I agree we're going 2.5 soup. The bed is going to 128. I can confirm by the lasers that the patient has moved in the correct direction. Later on, of course, you can layer on that reasoning. So even though I know you agree, you're my second. I'm not perfect and I can make mistakes. I might move the bed incorrectly, or you could mishear me. The habit of nodding in agreement through body language is addressed in this situation, and the confirmation through vocal communication is reinforced for the future patients by the student. Again, this is feedback that is very immediate. It's very specific. It addresses a behavior, essentially vocalizing and communicate, and it doesn't interrupt the workflow and benefits the next encounter for the student. The next tip that we look at is at expectations, the idea of being clear and explicit about what the student should be doing and their goals. Here's an amusing Dilbert comic strip, which will go through it. So essentially, this idea that you don't understand, or when you do give direction, the student may not understand what's happening. As another example in the setting of RT, let's take an example of when the RT has told the student to set up for all sites as an objective. A few days later, you might notice that the student isn't completing the full setup, so you forgot to verify the setup and the student is apologetic about it. Sometimes the student doesn't understand or hasn't grasped the full idea of what you want them to do in that task. So the student has interpreted it in another way. I thought you wanted me to just work on the manual manipulations. We often know what we want students to do or what to happen inside the room. However, the student may not be thinking the same. Students don't often struggle because they can't do a task. They struggle because they're not sure of what's expected of them on a daily basis. So as an example, students can often ask themselves, can I do this independently? When should I ask for help? Should I ask that question now? Am I doing good enough? And as a result of this, it can affect both student and supervisors. When expectations aren't clear, students begin to hesitate or overcheck, sometimes become overconfident. They experience anxiety, which can demonstrate inconsistencies of completing out a task. And equally, staff face the same uncertainty too. So they can step in too early or too late, and that impacts the supervision given or the early intervention of corrective action when you do your teaching. This leads to frustration, but also leads to time being wasted. The evidence tells us clearly that clearly articulating these learning outcomes, the role, the assessment criteria in placement reduces the anxiety, it supports the learning, and promotes consistency for clinical educators. That's all the RTs in the team following the same playbook for the student, preventing any conflict of instruction, direction, or even supervision levels. So clarity actually saves time and will save you a headache down the line. For example, some of the instructions that we can give to students are You assisted with the pelvic setups the last few days. Today, I expect you to take the lead and set up this prostate patient up independently. I'll be here if you need me. For the next few patients, I want you to introduce yourself and complete the ID out loud every time. Today, I want you to focus on calling out the imaging details before acquisition. These sentences take seconds, but they prevent confusion, they are direct, they turn the supervision into progression, and make learning feel a lot more supportive than stressful. When expectations are clear, students feel more confident, supervision feels safer, the anxiety drops, and teaching becomes more easier. And that's the power of the clarity in expectations. The next tip we look at is time loops. Time loops was a suggested strategy posed by the HSCP. It aims to ease the educative burden on supervisors during the intense periods throughout the working day. It doesn't necessarily eliminate the student from the clinical setting, but it allows a lot more breathing space when needed. So how does this work? So the traditional teaching method in clinical setting is usually done on a one-to-one scenario. In a clinical day, there's an RT team and there's one student who will shadow, observe, participate. However, not all situations within the day are viable for the student to engage with, such as an extremely anxious patient or an emergency treatment or complex techniques where everyone is under pressure. Time loops aim to give students a task of an independent task where they can do self-directed learning in a clinical setting without the need of a supervisor present all the time. So not necessarily sending the student away, but giving a task or a responsibility that they will incorporate or improve on when coming back into the clinical workflow. In this example here, you can see that throughout the day, the staff encounter a couple of scenarios, so an emergency treatment or a complex case. During these periods, the student is sent off to do certain tasks. In this case, the student is given the task of reviewing the identification procedure and also to learn from a planner about the DVCs of a bladder. What happens is the student reintegrates into the clinical environment and applies the knowledge that we give them. So as an example, we can see here, and it's very important, I suppose, when you do send a student away, is to be very intentional about addressing a knowledge gap or a developmental concern that we have or that we've identified while we've treated with them. And then when it's incorporated back into the day, that we test them on that. So that could be on a clinical patient or it could be through questioning. In this example, a complex patient where the student is not able to engage with is given the task of reviewing IGRT intentions to apply later in the day. So at the start of the day, we can see they have standard patients running from 9 to 11 o'clock. Unfortunately, at 11 o'clock, we have a complex patient that is scheduled in. At this point, maybe the ORTs are not able to provide education during this period. So the student is given a learning task where they're reviewing imaging protocols so that at 12:30, when they come back into the clinical workflow, they can provide information about what they've learned. So in this case, we're giving them clear instruction to review the stable positions of a match and say whether the patient's, in this case, prostate, are intolerant or not intolerance. So it's giving ultimately So the learning that student does contributes to the ongoing workflow and reduces the teaching required by the educator during the actual clinical scenarios. Another example of this is during a machine fault, a student is asked to review a patient and prepare scripts for a first day information chat with patients. Why is this helpful? Well, the student hasn't stopped learning. The clinical work continues, and the learning or the activity that the student does again contributes to the work, and this reduces the work for the staff and reduces the teaching required by the educator. In this scenario, the student contributes to the unit workflow, is given responsibility, and is kept well incorporated into the clinical environment. Time loops aims to give educators space to focus on the task at hand, but does not stop the learning for students. With time loops, it's not just about sending students away, it's about the application of intentional learning tasks and activities that will provide space for the clinical educator, and it ensures that you don't lose the education in those spaces. The final tip we discuss is normalizing the variation. So students often rotate between educators, machines, and sites. and they don't notice the things that are always done the same way. It could be the educator's teaching styles, the equipment, the protocols that are different. Without context, that variation can feel confusing, or even like they're doing something wrong or incorrect, or being put at a disadvantage. But in reality, most variation reflects clinical judgment, experience, or local protocols, not poor practice. Research supports this, that in placement, we expect variation, and it's not a flaw. Real learning happens when variation supports the clinical judgment. Let's have a look at some of these statements that supports this normalization. You might see this done differently on another machine, but this is how we apply the evidence in our protocols. You might see imaging done different on your previous placements, but we choose to do daily online imaging for everyone because you've seen a tattoo setup, an SGRT setup. What do you prefer, and what do you think are the advantages and disadvantages? You might see one tutor focus on positioning with you and another on imaging quality. They're both looking for the same outcome. These sentences reassure students and help them understand that the reasoning behind the practice. Our goal isn't to train students to copy one person's way of working. It's to help them become safe, adaptable OTs. When variation is explained, it becomes a learning opportunity rather than a source of anxiety. So variation is not the enemy. Variation is the key to having knowledgeable and clinical competent practitioners. Normalizing variation helps students focus on learning rather than interpreting the different differences and inconsistencies or even the unfairness in teaching. So now what I'll do is I'll pass you on to Susan to give a few key takeaways from what we've just discussed.
Thanks, Sany. So that just brings us to the end of our talk. So firstly, we would just want to say that clinical education isn't just about supporting students. It's actually a workforce strategy. The experience students have on placement directly influences, as we said, confidence, patient care, and where they choose to work. Also, learning doesn't only happen through teaching sessions. It happens through participation and belonging and through being part of a real clinical team. And often it's the small everyday actions that make the biggest difference to our students. So as we said, including them in conversations, giving brief feedback, or simply talking your thinking out loud. Students just don't just learn what we do. They also learn how we think and how we behave as professionals. It's not about doing something extra or perfectly. It's about being consistent and intentional in the small things that we do every day. If we get those small things right, we create better learning environments, safer care, and stronger teams for the future. So we'd hope that even if you take one tip from what we've discussed today and use in your practice, that would be a positive. So if there's any questions.
Great. Thanks, Suzanne. Thanks, Sany. That's a lot to take in. I really like your statement about that clinical education shouldn't compete with service delivery, that it happens within it, and that's a challenging, I think, statement for us all. But I think you've laid out some really nice examples of how it is possible during complex treatments and very busy clinics. And that brings us, I guess, to one of the questions. So one of the strategies you talked about was this utilizing time loops and identifying maybe gaps in learning where the student can kind of head off and focus on that specifically at that time. So I guess in terms of developing resources or developing what you might be need available for the student in that time loop, should that be done in advance? Should it be done like on a weekly basis, or how can we integrate that into our workflow? Because if you've got a complex patient coming in, you probably don't have that moment right then to prepare those resources and give the students. So is it something we should do in advance for the time loop?
It's definitely beneficial to have things prepared behind these kind of cases that do pop up. I mean, we should have our protocols kind of like close by in terms if we need access to them too. So even having, our flow charts or having, folders for the students to go through if they do need things, with regards to the patients that we might come across. So like bladder protocol and stuff like that, or even the patient information that we might be providing to patients, they should be all available at hand, really. So definitely, if you can prepare in advance, it's always helpful. I mean, machine breakdowns, a service day, like those occasions would be the best. But at that time and moment, you should be able to plan for your day to see that you might encounter a complex patient where a student may not be getting involved.
Great. And if I might go with another question. So in terms of, I suppose, developing clinical judgment, which is quite a difficult, tangible thing to identify for students, but we all know what it is. So how, and that kind of clinical reasoning, and you touched on some strategies. So for developing that, say for students probably further on in the program towards the end of their learning, how can you encourage and promote and maybe rationalize your thinking for students at that level of the program?
I suppose if we were looking at making the expert thinking visible, it's also something, I suppose, for those late years, we could also flip back to the students, and for the fourth years, maybe ask them to make their expert thinking visible, because at that stage in those late years, they should know exactly what they're doing and why they're doing it. So it's kind of also a good way to learn from them and for us to understand what they know.
Okay, so get them to teach you, kind of vice versa.
Yeah.
And you kind of and that kind of teaching, I guess, and you touched on it as well about new graduates, how they're maybe a more approachable individual for the students to inquire around. And I suppose students do find that very useful. And I suppose then how do you promote that within the recent graduate, that that is their role and they're well capable of teaching students now that they're at that end? How can you encourage that within new graduates to make them feel comfortable that that's their role and they're well able to teach in that context?
I think from our experience that we feel like the new graduates seem to welcome the students. I suppose they're just so fresh out of being students themselves and realise how difficult placement can be at sometimes and how challenging it can be. I think they embrace that role and like how hard that kind of transition to practice is. So I think if they can be part of it and ease it for the students.
Great. And then just another, so you were talking about the kind of expert thinking and the micro teaching. And I was just wondering, so what, in terms of what's the difference? So I can see the micro teaching is it's that kind of in that instance, but how do you teach, I suppose, the critical thinking skill I talked about earlier within that moment, or is that not what's done in the terms of the micro teaching? Is that a separate thing?
Yeah, so I'd say like with the micro teaching, you're just highlighting the steps of whatever the procedure or the actual educative moment is. Mm-hmm. So you're not trying to give, like you may not have the time to actually deliver the expert teaching at that moment. And like often you might find that you're delaying treatment processes. I mean, like if you had a patient whose bladder is holding there, you may not have the time to go ahead with it. So with the idea of micro moments, it is just to give the steps and pass that on to the student. And then later, and like I said, you can layer that clinical reasoning on afterwards when you have the time. Like, for example, as you're walking out of the room or as the beam is being delivered, you have the time to actually say something at that point. And this is where like a lot of those tips that we've discussed, a lot of them can be like amalgamated into each other, or you're kind of picking from each other to deliver like the overall, I suppose, educative scenario for the student. So it's not just kind of about, being selective with one or the other. Often you will find that the different tips will kind of overlap each other as well.
Okay. And another question, if I might. So about feedback, could this daily feedback be used instead of one final feedback or review session? Is that what you're promoting?
We'd be promoting daily feedback just, I suppose, for the students. And a lot of students themselves have actually requested daily feedback. But as part of the assessment form, then that is like a sit-down process, which is separate. And so that still needs to be carried on. It's not going to replace that.
Okay. And again, just someone else, really nice presentation. We all think about the feedback session. We all know we still have memory of it, even this many years on from graduation. Rather than focus on the smaller opportunities that may be well received and less confrontational. And I like practice examples, so they really like that incorporation. And I guess that's a skill that we have to learn, isn't it, really, that it's not something you can just click into moving forward. So what kind of, practical things in terms of giving that feedback? Because I guess the more you do, the better you get at it. But that kind of micro feedbacking sessions, how could we, as practicing RTs, get better at that, or start it and get better at it, I guess?
I think definitely selecting like one good thing that you've seen, one bad thing that you've seen, or an area of development for the student is definitely the starting point of it. But what's also quite important is to get the student's viewpoint on what they've been experiencing as well. So like you want to get their interpretation of what their abilities are as well, because sometimes they can see that they're doing well. Well, they feel that they're doing well, but maybe they're not. And I think as part of feedback, you do need to integrate a lot of that discussion with them. And this is why I like going back to the previous point about having a structured sit down session with the student about feedback is so important. Like the informal kind of feedback that you can give on a daily, day-to-day basis is very good. Like it's very helpful for the student. But when you do need to address situations, like you do need a sit down session with the student.
Okay,
Yeah.
so sorry, Susan.
Oh, sorry. I was just going to say, kind of reiterate what Sany said. Like it's always like a good idea to kind of start with something positive, then kind of give that critical part, and then kind of end with something positive as well. And like there's an idea of feed forward, so kind of always say to the students, so going forward, let's focus on this, or like it's always good to leave it on a positive note.
Okay. The old compliment sandwich. And I hear what you're saying, because then you have set this kind of expectation that this is the point we're looking at, maybe today or this week, and then you've identified that point, and then it's easier probably to give feedback during the week. Then you're doing that well there, or maybe not so good for that site or something like that. That by having that initial talk can lend itself to those kind of smaller feedback sessions during the week. And then I guess just in terms of, if there's any other questions, please feel free to pop them in. But as maybe a final thought, in terms of us reflecting on our experience of teaching, and part of it is learning what we felt went well with the student and what didn't. Kind of, is there any strategies as us professionals reflecting on that interaction with students? Because sometimes, when you have those hard conversations, that's difficult. Or if conversations didn't go the way you wanted, how we can reflect on that and kind of improve for it the next time around. Sorry, that's a bit off the scope of the talk. But we're kind of maybe chatting to our peers about it, or
and like the practice tutor is also there,
Okay.
to chat with. So like if anyone has any issues or that they want to kind of learn from what went wrong or what didn't go wrong on placement, like the practice tutors are always there to see if we can offer any help.
Like even from my own experience, like talking with Susan, talking with our managers, and talking with the RT links, even back to the school, to kind of define, like, did we handle this situation correctly, or was there any other opportunities or missed opportunities within discussions with students? So for example, there's a lot of resources from the school that come from like handling underperforming students or students that are in distress, that we may not have picked on, especially with regards to being in clinical. I mean, the oversight comes from the college, so they have a lot of resources available for you to kind of pull up on if you do struggle with handling the feedback or handling a distressed student or situation with regards to like poor teaching or anything like that.
Great. Yep. Thank you. And then maybe just one final question that has come in. Can you give some tips and tricks for students on how to proactive work daily practice? So maybe tips and tricks for students, how they can be more proactive, I guess, in their interactions with us.
Well, it really depends on the year of the students. So like, I suppose the first, like all the students go out with their objectives and they know what they're meant to achieve. And like, they all have competencies from year 1 to year 4. So before our students go out in placement, we usually kind of inform the staff of what is expected of the students, and the students are also aware of what's expected of them. So I'm not sure, I suppose, just to be aware, I suppose, of the competencies that are sent out, on what's expected of them, and maybe even kind of have a chat with the student on day 1 or 2 and go through what's expected, like what the student, as Sandy said, that clarity and expectations is so important, just so the staff know what's expected and the students know. But
Great, yeah. So
familiarising yourself with the competencies for each year.
Yeah, so in the Irish setting, the students would have very specific competencies they need to achieve within the placement that they're on, and that can be a good tool for directing students. In other settings, probably just maybe speaking with the students, I guess they will know their competencies and what needs to be assessed on that given placement. We might have one more question if you're willing, guys. Thanks for a great presentation. I just wanted to ask about delivering feedback and when there are inconsistencies within staff members in the team, and maybe the feedback isn't consistent, how that might be dealt with.
I suppose in the Irish setting, again, we like to have kind of a unanimous decision from the team. But again, as Sany said, there's so much resources available from the school here, and like even online modules that the staff can kind of familiarise themselves with, so that they're all kind of on that even keel when they are given feedback. Like the resources really need to be utilised. But I suppose if you're specifically talking about a scenario where the team can't come to a decision, I suppose where there's a student link in the department or the practice tutor, like we'd have to step in and just try and hopefully solve it.
Yeah, I guess it's quite well structured in our system that the processes are there and how that decision is reached and how it's agreed upon. It may be less structured in other systems, but I guess, as you say, trying to reach a unanimous decision would be a key thing, and whoever is probably the principal person looking after the student on the LINAC would lead that.
I'd say as well, like, it's important to go back to what your competencies or what you're trying to accomplish with your student. And I wouldn't dismiss that if one staff member might have a concern compared to your team members, because it could be an issue that highlights later, or when they're qualified could become a problem. So I think having kind of a consensus on the unit, like Susan was saying, is very great and it's good. But to address and to further investigate on what that issue is exactly. So like it could be an issue like the one member of staff may have not seen a student perform in a certain task or something, or the way they might conduct themselves. And I suppose like you kind of have to separate out like the actual task that the student does versus maybe a behavioral or a personal aspect that they might have, maybe the way they speak or the way they act on the unit. And if it's an issue, it needs to be addressed early enough that the student can amend that, and it needs to be voiced as well. I mean, if there was an issue, like has it actually been addressed with the student, especially if 3 members of staff are happy with it, but then one member isn't? Has that one member actually discussed it with the other team members, or have they said it to the students? So it's quite important that like if there is an issue, it should be discussed with the team members, and it has to be addressed prior to a student even going towards their final week, or as early as possible, essentially.
Great. Yeah, that's some great points. I don't see any more questions coming in. Is there anything else, Sany and Susan, you want to finish on?
Even if you can take even just one tip and integrate it into your practice, like that's a good starting point. And I suppose those tips that that we have mentioned here, it aims to reduce the risk of students failing or struggling while on treatment. So integrating any of that at all would be very beneficial for both yourself, your own sanity, and also towards the students as well.
Great. Listen, thank you very much. I think there was lots of nice strategies there. I think that we can all hone in on one or two that we can bring forward. So thank you very much for your presentation and for your discussion there at the end and our Q&A questions. This session will be available online in the coming days. So if anyone had to drop out early or wants to send it on to some colleagues, feel free. It'll be up on our discipline website on trinity.com. Okay. Thank you very much. And
thank you.
Thank you.
Everyone has a good day.